Thank you very much. Of course, I would like to congratulate this faculty. I think it's wonderful. 200 years is great. So congratulations to us all. So my topic is indeed the role of the dose. So I am a hospital pharmacist, clinical pharmacologist, and it said my name Catherijne. Well, not from Italy, it's just from the Netherlands. Catherijne is my name, Knibbe, and working here, Leiden University, LACDR, and in the Antonius Hospital in Nieuwegein. What I do, actually, my topic is individualized drug treatment for special populations. We just heard an example of a drug being developed. Well, normally, if everything goes okay after phase 1, you will get to phase 2, and the drug will be tested in strictly selected patients, and then in phase 3, in a larger group of strictly selected patients still, to see versus placebo what the exact efficacy and safety profile is. And if then you succeed, you will get access to, what is it, US market or a European market, and you can sell your drug and actually try to, and it will be used in hospitals. Well then, of course, in the hospital, what are we treating? We're not treating strictly selected patients. So we do have very old patients. We have a lot of obesity. We have a lot of obesity in our clinic, I think in all the clinics, but we're a big cardiovascular and oncology center, and that is mainly, we have a lot of obesity. Of course, we have children and pregnant women. The slides are a bit old. I think they have been hit on the head, but anyway. So this is what we're dealing with. We have new drugs that come to the market, they've been studied in strictly selected patients, and then we're going to use them in patients. So what is then happening? We don't have normal subjects. We're all different, so we will be using all these drugs, and we're not looking at we don't look at the label where it says you can't use for this and not for that. We have to treat the patients, otherwise you're withholding treatments. So what happens if you dose drugs to a non-normal subject? Well, children is a large population. If I have time, I will touch upon obesity, but I think we're a bit behind schedule, see what we can do. But a nice example in children. Well, you may know that for drugs used in children, only a very small percentage of the drugs are actually licensed for children. That means in the label there is information because studies have been performed in children. And why is that? Doing research in children is difficult. They cannot consent. Numbers are small, so that means that there's not much information. The information that's out there is mostly empiric. And what's empiric? Data. That is that actually drugs have been used because they have been around for a long time with experience in adults, and then we have children we want to treat and we give them a fraction of the dose. And on what shall we base this? Well, actually, when you enter with a child, I don't know whether you've done that, into a hospital or you go to see a physician, the first question they will ask you, what does your child weigh? And because they use that for dosing of drugs and many other things, and that is important because there's some sort of assumption behind it that I will be discussing. Well, there's a different approach for obesity. For obesity, our clinicians think differently. This is our natural evolution now, so this is what we're facing in the clinic. And actually, most of the physicians, they would call me and they would say, well, I have a very large patient, 250 kilograms, what shall I do with antibiotics? What shall I do with anesthetics? Analgesic, can I give 3 times the dose? I don't think so, but what is the dose I should be giving? So very often, they don't dose on the basis of kilogram body weight in obesity, in contrast to children. Well, this is then the current situation, is that if you dose a kilogram body weight as is being done in children, you just consider a child a small adult, so just a part of an adult with the same composition, etc. And the question is whether that's a very good idea. So this is what happens, and usually this has been done in the past on a drug that has been on the market for a long time. So what you can see, for a certain drug we decided for pediatrics between 2 years and 18 years, you dose 3 milligram per kilogram of a drug X. And then there is a child that is younger than 2 years, and then the pediatrician and the clinical pharmacologist, they think, well, what should we do? Shall we give the same dose? Well, very often they decide to give a bit lower dose. Very often that's a very good idea, because the metabolism expressed per kilogram is often lower in newborns, in infants, younger than 2 years of age. And then they find out that there's a middle group, the toddlers, very often, for many drugs, they per kilogram need more. And then for adolescents, they will find out that if you continue on dosing, if it's the adult dose, if you continue on dosing per kilogram body weight, you will end up with higher dosages in adults, and that is not what you would expect. So then they would give a lower dose. So what do you end up with? And that's very often promoted to scale to children, is to use allometric scaling, which is on a log-log scale, has a slope of 0.75. If you want to scale the dose to children, use 0.75 from an adult dose back to children. And then, of course, this is not such a bad approach, actually. The only thing is, in the extremes, it doesn't work at all. It's very unsafe. So we've seen many problems here in the neonates, particularly preterm neonates, so prematurely born neonates. But also in this other group, the real question is, should you continue on dosing? Could you imagine there are also drugs that you would give a lower dose? Think of analgesics, morphine, for instance, because it influences breathing as well, so you don't want the patient to stop breathing. So these are examples where we actually do not know how to adjust the dose. Well, of course, for these extremes of weight, you could also say, well, don't you know how all the physiological parameters of the biological system of the human being is changing? Don't you know what the blood volume is, how much fat a patient has? So the composition of the patient, but also physiological characteristics like what is cardiac output, flow through the liver, what is the flow through the kidneys? Can't you sort of predict? Well, actually, there's quite a bit of information that can be used to predict dosages. So particularly in early drug development, it has quite a good position actually within the drug development. We call that PBPK, physiologically based pharmacokinetic modeling. You can do a lot of prediction based on physiology together with drug characteristics. But the whole issue is, particularly for neonates or morbidly obese patients, this information is not available. So you would still need information that you would get from patients, because these predictions are not so valid. So the question is, what do we know? And what are we not aware of? And it's probably too much to do predictions. So you can do predictions, but they may not be that reliable. So what can you do then in terms of research? This is of course what you would want in pediatrics, in pregnant women, in the elderly. You want to know the relation between the dose and the effect in relation to safety. Well, specifically referring to the previous speaker, this is of course what you want to know in any group. So even in healthy volunteer, you want to know the exact relation between dose, effect in relation to safety. And you want to know that in neonates and in pregnant women and hopefully first in healthy volunteers. Well, for that, very often for this special population, the concentration can be instrumental, but you have to remind it in the end that is the drug effect that is important. So if this relation, for instance, is different in this special population, you need to be careful with these type of predictions. So efficacy and safety should always be taken into account. And then what is happening? Referring to the French study, they were probably taking samples from these healthy volunteers as well. So they wanted to know the kinetics. And this is what you typically see. You have 8 individuals. Well, we had 6 in the French study. And they would take a lot of samples per individual. You can fit the line here. They went to sleep, so they didn't bother them. And next morning they took another sample and then they go home. Well, could you do this in children? Well, of course not in healthy children. Maybe not in sick children, because you don't want to put too much burden on them, so that really depends on a lot of things. So here we have additional legislation, of course, small numbers of patients. Well, you cannot do many venipunctures children, they don't like it, the medical ethics committee will not allow you to do that too much. So the information you will be getting is limited. This is also a fun one. If you do oral drug studies in children, particularly in the young ones, it's very difficult to give oral dose. So what happens, the mother may crush the tablet and then put it in the applesauce, and then they try to get it in, and then they don't get everything in, and then they try again, or they give a little bit more, or they use a solution. They say, well, this tablet is not working, it can swallow, let's do the solution, and then the bioavailability is not the same as the tablet. So this is the oral studies is very difficult. Actually, I hate them. I prefer intravenous studies to start with, but this is a very difficult part. Well, this is low percentage of informed consent. You could imagine as a parent you do not want to give informed consent for additional blood testing, etc. But what we've seen in our research is that the more severe the disease is, the higher the informed consent is. So if you would have low impact diseases, it's difficult to get informed consent. You could get as low as 20%. But severe diseases or low burden studies, you can have very high percentages. Well, this is what you may end up with, and that is the truth. For one child, you may end up with only 3 samples, or only 1 sample, or 2, and then you don't have informed consent anymore, you can't use the line, they're off to another ward, so etc. So this is a very difficult situation. Can you get data out of it? And that's where we need science. Here, another description, you could have unbalanced data sets, so for one child you have more observations, for another child with 1 sample, or you would have just 2 or 3 samples at different time points, different dosages of this drug. And then what can you do? Well, this is where the expertise of what Catherijne, Maynard Donov started this whole population PKPD modeling, and I'm very happy to contribute to this group, proposed to use at all times, and particularly in children. You use a statistical approach where you would analyze all these sparse samples together, where you would fit only this thick line, this is your population line, and with inter-individual variability on the parameters that are behind this population line, you can still individually fit the data of individual patients. And this has been a very powerful approach. And if we look back, when we started this type of research like 15 years ago, this was really not standard. So pediatricians would just say, we can't do better research in children because there's no way if you have 2 samples to do any of these type of analysis. And now I think we've gotten to the point where in all the Netherlands and a lot of parts in the world, when these techniques are used, you can answer your research question. You can predict what exposure in different doses, even in neonates, even in 0.5 kilogram neonates. And I'll show an example of that. Well, this is to show, this is what Pool Volitodo prepared. I hope it's working. Probably not, actually. We'll see. Oh yeah, this is what's happening. So you will have here your parameters that is behind your model, and this population approach, and here you see the population line. You get iterations to get all these data taken into account, and you do consider that 1 sample is from 1 patient and 1 sample is from the other. So that is very important. And of course, the not very nice part about this animation is that this is rich data, so that's something that I realize now I should provide an example. But the good thing and the power of this tool is that you don't need to have samples for all individuals at all times, and that is what really has contributed to get much more knowledge, particularly in neonates. So what we've been doing, and from which I will show an example, is that, well, as I have a clinical background, we did start with specific drugs. So my example will be on morphine, and then you think, oh, morphine is extremely new drug. How can you study morphine? We know enough of this. Well, actually that's not true, and particularly not for children, so I'll show you that. But this is of course how it started. We started with a specific drug, and then we did a lot of research. I'll show you that in a minute, to get to a good dosing guideline for very young children, to get to a safe and effective dosage. And then we saw how much effort that took, and how much research we had to do. And then we thought, well, can we use the information that we derive from one specific drug to other drugs that are metabolized through the same pathway? Like in this example, morphine in the human body is glucuronidated, so can we use some of these maturation functions and translate them to other drugs? And that is where I have a VD grant for, and we're currently working on. So this is the, so this is what I wanted to show to you. Here you see clearance. So that is a predictor of the drug dose of morphine in children. And here you see body weight of the children. And what is difficult to see, but body weight is in grams, that we have 0.5 kilogram neonates, quite a bit. So the all prematurely born neonates in the data set until 3 years of age. And this is just a typical pediatric ICU population. I think 80% is younger than 2 years. They're preterm neonates in this department. And actually in the past, these prematurely born neonates, they would just not survive. The good thing is they're surviving. The bad thing is we don't know anything about their drug dosages. So that is why these studies were being performed. And what you can see is that this is not a linear function. What you can see is this is an exponential function. You actually see that the children younger than 2 days even have much lower clearance values. That this is an exponential function. If you put that on a log-log scale, this is about a 1.44 slope, and with even a big reduction when DNA is younger than 10 days. Now, of course, you can imagine that this exponential function above 3 years is not going to continue to adult age. So you need to get to a certain point where this maturation goes slower than it goes in early life. So this is where we really need the Faculty of Science to develop these type of concepts. We do not think of all these functions in the clinic. Actually, most pediatricians, they hate these type of functions, but as an innovative faculty, I thought we would show it here. What you can see, this is a log scale. We have clearance again of morphine versus weight, 0.5 kids. But here adults are included and older children are included. And what you can see is this initial function of 1.44 slope is changing to a lower, is changing to about an 0.7 slope with weight. So the exponent itself is changing with weight, and that makes you a very flexible function. And this function is actually was developed in our department, and we've seen in the literature that particularly in wide ranges of ages that are being studied in pediatric research, also other groups are using this function just to describe what we see. And that is important because that will guide us dosing of this drug. Well, this is the studies we did. So to get there, I'll skip that. What is really important is that we go back to this microgram per kilogram per hour dosing. So this is just standard of care. All over the world, morphine is being dosed in microgram per kilogram per hour, no matter your body weight in pediatric ICU. So that means if we know that this dosage is per kilogram, and clearance is exponential with body weight, that means that your youngest individuals, your 0.5 preterm neonates that are just born at the highest concentration, and the 3-year-olds have the lowest. And of course, in general, you could say this is not what you want, but this is actually, this is really what happens in all over the world, not in the Netherlands, I hope not anymore now. But what we then said, well, you need to give an exponential dose. You give a power dose, microgram per kilogram to the power of about 1.5. And if you do that, we assure you, is what we said to the pediatrician, we assure you that all your concentration will be about the same. Then you can measure the effects, and then you can decide what target concentration you want to aim. Well, this needed some courage from the pediatricians, because first they have to believe all our models, which they find difficult to follow. Then they need to convince the nurses and all their systems that they should be dosing in microgram per kilogram to the power of whatever. So we thought of giving them a table, which they still didn't like. So it's now implemented in their system. This is a horrible table, of course, and a pharmacist of the Sophia Children's Hospital said, we're going to get medication errors, etc. This is a great disaster. And then we said, okay, not directly in clinical practice, we're going to do a study first. We're going to evaluate this exponential dosing scheme and see what happens. So that's what Elke Krekels did, who got her PhD and has now a position here in our department. And we did a prospective clinical study in Rotterdam with our friends from the ICU. This is the morphine dose versus body weight. So here you see all the neonates between 2 and 4 kilograms, so these were term neonates. Here you see that the normal traditional dose is 10 microgram per kilogram per hour. This is what we proposed. The line and the dots is what these children over 48 hours after surgery actually needed based on their comfort scales, how you measure pain in a pediatric ICU. And what you can see is that the starting dose, which is the line, is just about the same as the dots. For older children, so they were more than, up to 1 year of age, what you can see is about 60% is around this line, but there's also a group that is less sensitive to morphine, implying that the sensitivity of neonates is much higher than it is in older children. So this actually tells you what dose you need to give. And is this relevant? Yes, it's very relevant because, as I said, particularly for the preterm neonates, what we propose is then a 50 to 70% lower dosage compared to the past. And then you think, well, that's nice, maybe then they're a bit less sleepy, that they're very young neonates anyway. Yes, but the whole issue is if they need invasive treatment like extracorporeal membrane oxygenation, so that is an external lung, then they will be using morphine for prolonged times. And what has happened, as I said, in the past, these children would not survive. They do now, and in the past they went home with clonidine and midazolam because they had severe withdrawal symptoms. And actually what happens now is that you can actually prevent withdrawal symptoms because of adequate dosing. So in that sense it's very relevant, and then again, particularly for the neonates, is where we gained. So we're almost there. This is the last slide I want to show. This is work that Elke has been doing. I showed you this very nonlinear function of morphine glucuronidation between preterm neonates and adults. And the main question would be, can we use that function for all other drugs that are glucuronidated and newly developed? So if you have a new drug, you would have the optimal adult dose. That would be brilliant if you could scale that to neonates and have a better first starting dose in your clinical trials in neonates. Because that's actually what is needed now due to European law for all new drugs. And what Elke did, and it was published in CPT, I don't know why it doesn't show up, 2 papers. Actually, she first did a prediction to another drug that is glucuronidated in the human body, and an antiretroviral drug, and did a whole simulation study for all different drug characteristics, and actually she showed it works pretty well. I don't have to go time into details, but maybe some other time I can explain a bit more. But what we've seen is that there may be some restrictions to this extrapolation, and that is what we're currently working on to get exact track on what are the drug characteristics where we can use these type of functions, and what are the drug characteristics where you need other approaches to get to good predictions. That will bring me to the last. Anyone interested? Anyone interested in more? I haven't told you, but the whole thing is that I thought, oh, it's so nice I can have a lecture here. And then I thought, man, it's even much nicer. I have 15 minutes. But of course, yeah, when I read that and made my slides 2 days ago, I just returned from the US and I was in another time zone. I didn't really take your lecture into account, so that's why it's too many slides. So many other nice things. It's also, yeah. Okay, this is to summarize, I was just joking. I actually did this on purpose, hoping I could have another lecture someday. Okay, good. There's a very nice stuff on morbid diabetes as well. But this, I think morphine is a nice example because it shows all the way, it shows in children the relevance and also what statistics can do to improve clinical practice. This is what we do. We derive dosing guidelines for specific drugs. We're working on tune an approach where we get better concepts for scaling. We can only do that if we have hospitals, if we have the LHCDR, if we have colleagues from the PPPK group to get to this. And this is actually what you would like to get. You would like to get to models to predict age-related changes of drugs and get to better safety and efficacy of drugs. Well, thank you very much.